thank you so much for inviting me to come to this, because one of the things I'm absolutely passionate about is moving the psychological aspects of care up the agenda for all our NET patients, because the way in which one feels about your condition and living with your condition well is absolutely central to the sort of journey that everyone has with these conditions. So I've been working with NET Patient Foundation and AMeND for since 2014 with AMeND and since 2017 with NPF. And we're collecting quite a lot of data now about the impact of these conditions on emotional and psychological well-being. And to my knowledge, this isn't really being done in any other countries as yet. So we're very keen to share this information and also to grow contacts with other people in other organisations on this. And one of the things that was very key to the way that we wanted to set up the telephone and Skype counselling service was we're very aware that patients spend a lot of time going from pillar to post with their appointments. And although they might have been offered psychological support in services in-house, it was actually very difficult for them to access them, just logistically. So we felt that it was important to be able to make ourselves available to clients across the board, really. This has involved some flexibility on the part of us as the counsellors involved. I was talking to someone who lives in a remote part of Wales who manages to get telephone signal in her lambing shed. Now, this is not something that as a psychologist I was trained to necessarily do, but it's been very helpful for her. And we have a very specialised approach where we withdraw on attachment theory and mindfulness CBT. And we work also very closely with specialist nurses and GPs to provide very joined up care. Okay, so this is a graph that you're familiar with from the INCA survey last year, and I wanted to talk a little bit about Marjorie. I don't know whether you can, she's gone a bit small here. Marjorie is someone who contacted the counselling service and is very typical of a patient who has been living with her condition for a very long period of time and sees herself as someone who is perhaps an expert patient. But one of the things that Marjorie has started to struggle with is that her condition has started to change over time. And she has a very particular relationship with her consultant where she enjoys being a patient who is doing well. And this has somewhat inhibited Marjorie from feeling free to talk about the symptoms that she's now having. She likes being a patient that is shown off to student groups. She likes being a patient that is seen to be living well. And Marjorie rang the counselling service with some sense of shame and embarrassment about what was going on behind the scenes. And one of the things that Marjorie disclosed to us was this was the first time that she had really talked to anyone outside her group of family and friends about how much she was struggling. And she's a very typical patient in that, in some ways, with ordinary cancer patients, the impact of diagnosis can hit much earlier on. With NET patients, it can hit at any point in the disease journey, sometimes at the point of re-diagnosis, sometimes at the point at which symptoms really start to kick in. With our MEN patients, for example, we sometimes find that they will have been given a diagnosis, but it'll be many years before they really start to feel the impact of their condition. So this NET cancer did not conform to the ordinary model of diagnosis, shock, treatment. It's a very different model. I've also put up here Nick, who is someone we spoke to quite recently, who's a younger NET patient, which are a group who, of course, have their own particular needs because of where they are at in their life cycle and their developmental stages and what's going on in their lives at any one time. And Nick was someone who I was sort of reminded of when Kathy was talking about someone who really did not know what to make of what he was being told about his health. He was someone who went for a relatively straightforward operation, and his NET turned up as a byproduct of that. So this was a huge shock for him. And Nick, as you might imagine, is someone who is already somewhat sleep deprived, who is going through a huge life transition in becoming a young parent, this is not the sort of information you want to have to process at that time in your life. He already had a relationship that was somewhat fragile, and he was again a typical patient in that when he tried to talk to anyone about what was going on with him, he was met with that blank look of incomprehension. Well, I've got this thing that might be a cancer or it might not be, I'm not really sure. Okay, good luck with that, Nick. Yeah? It's not like you're saying you've got a breast cancer or prostate cancer where everyone moves in, everyone understands. So Nick was very isolated with his diagnosis and had got to the point where actually he was feeling so overwhelmed that he was not sure he could carry on. And again, this was a piece of information that Nick did not actively identify himself as suicidal as such, but I think you can see from that last line there that the level of distress that he was experiencing at this point in his life was considerable. And my colleague and I both worked with Nick and his wife separately to talk through the impact of this diagnosis and walk with them over a period of months until things became a bit clearer. Okay, so this is just to give you a little bit of overview, really, to the sorts of issues that people are bringing to AMeND and Net Patient Foundation counselling services. Unsurprisingly, anxiety is very, very high, and anxiety, one of the frustrations I have is that a percentage of my job should not be needed. And by that, I mean that there should be better communication, as Joe was just saying, in clinics. That the way that clinics are run, I still feel incredibly frustrated about that there is an ordinary level of kindness, care, and common sense in clinics in the way that consultants communicate information to patients who are very fragile, who may be absorbing life-threatening information. This is not the time to bring in a horde of students to sit someone down in the middle of the room and tell them information that will change their lives. It's not a good time to look clever as a consultant. Sorry to be blunt about this, but it traumatizes some of your patients. Now, there's some very interesting data in here generally, but I also just want to bring your attention to an unsurprising difference, actually, that we might find between AMeND and Net Patient Foundation patients, which is, do not be under any illusions if you look at the bar graph here at what is one patient described the minor bomb that can go off in a family network when you get the diagnosis of a genetic condition. And the reason for this is that at heart everyone is frightened, but it can also provoke and stir up underlying dynamics that may have sat bubbling underneath the surface for many years. Oh, of course we've got it from Uncle Bob, because that's what Uncle Bob's like. Yeah? Or, come on everyone, let's get together, we must all talk about this and we must now be one big jolly happy family. I don't really think I want to be one big jolly happy family, because I haven't forgotten when you didn't come to my wedding 3 years ago because you had a work event you wanted to do. So there are all sorts of fantasies that can get stirred up in families around how one should deal with a condition like this. And of course many families do step in, are incredibly supportive and deal with these conditions very well. But there are families out there, because we are very diverse, that means that all sorts of things get stirred up that compound the difficulties when you're dealing with these sort of diagnoses. And then I just wanted to draw your attention to our last statistic here, which is when I started working with AMeND originally and then Net Patient Foundation, both my colleague and I were quite surprised by the number of patients that disclose suicidal thoughts to us, because in some ways that should be counterintuitive. And actually patients themselves were often surprised by these thoughts, because they would say things like, I really, really don't want to die, but I find myself thinking about not wanting to carry on, about thinking about I can't do this any longer, about I have had fantasies of just taking all my medication in one go. And what we were very struck by was that patients weren't disclosing this anywhere else. They weren't disclosing it to family members because of not wanting to frighten them because of feeling very shamed. They certainly weren't disclosing it in clinic, because how would you disclose that in clinic? Thank you very much for all my treatment options, Mr. Consultant, but I'm feeling actually like I just can't carry on. There's not the space to create that sort of dialogue. So we really wanted you to know that there are percentage, and of course this is a tiny percentage in the overall population. We don't know how many patients are out there who may be really struggling. This is a tiny stat of a relatively tiny number. But don't forget, all of you who are here in this room as either patients or patient advocates have taken up your diseases and your conditions in a particular way. Many, many people out there are struggling in isolation. And actually, a number of people who contact AMeND counselling won't necessarily have much contact with the patient organisations in any other way. Now, having said that, this is not that patients were necessarily intending to act upon these thoughts, although a couple were, but it is certainly an important signifier of the level of distress that can be out there. Does that make sense to you? Okay. Oh, and this is another thing that we have become increasingly interested in, which is about how one lives well with the condition. Kathy's patient that she mentioned earlier, who was having all sorts of terrible symptoms, but was actually managing and living with their condition relatively happily, actually. And one of the things that we have become very interested in is how, over the course of a period of sessions, someone may come in quite a high degree of distress about their symptoms, particularly gastrointestinal nets. And what we've noticed is that over the course of counselling, people either feel differently about their symptoms, they can manage them better, they don't feel as troubling or intrusive, or the symptoms themselves seem to actually alleviate. And I mean, I always draw the analogy of, if you are someone who is prone to sort of tummy upsets, I'm sure you can all remember taking exams and that fluttery butterfly stomach or needing to go to the loo a lot. So how we manage our patients' anxiety may have a direct impact actually on their symptoms, but also how well they are able to live with and bear their symptoms. Okay, so why do NET patients have a particular need psychologically? Well, in the immortal words of Star Trek, it's cancergen, but not as we know it. And I would make a strong case that there are very particular needs for NET patients. The cure versus palliative care model of cancer that most services, psychological services, will be used to working with doesn't really apply. And we have a lot of patients who come to us because they may have turned up at things like Maggie's Centre groups or Macmillan groups or CBT counselling, and they've said, we just feel a bit awkward because we're not really one or the other. We're not really in recovery, but neither are we moving to a palliative care pathway. They're sort of somewhere in between. So finding a group where they can really feel held and understood is a real challenge for these patients. They're also, it's very psychologically demanding, the high level of unpredictability and uncertainty that we ask our patients to live with over time. We don't ask them to, they just are. Yeah? Because one of the things as human beings that we naturally gravitate against is we tend to like predictability and we tend to like certainty. If we want to get our kicks, we go out and seek them in very discreet ways by things like paragliding or dangerous sports, yeah? But in a managed and controlled way. This is very different. One of the things that patients also struggle with, and we spend a lot of time talking about with patients actually, is are symptoms of anxiety and depression, are they psychologically driven? How you feel about the impact of your condition and how it's impacting on your life? Or are they physiologically driven? Put simply, is it me or is it my NET? Yeah? Because it's very difficult to tell, and sometimes it is only in conversation that sometimes things can become a bit clearer, and we can have a bit of space and time to do that with patients, that they can then take that information back to clinic and help them think about how they then work with their consultants to manage their conditions. It's logistically incredibly burdensome. Okay, most patients will have files this big. They may be going to all sorts of clinics in different places. They may be travelling long distances. It's very intrusive into one's ordinary life. So it has an impact in that way, which is just stressful. Being a patient expert is something that is a real mixed blessing, and I think there is a real grief for a lot of patients in giving up the idea that you go to the expert professional and they tell you what's happening and they tell you how they're going to make it better. And, we all carry that bit of ourselves that goes, you get poorly, you go to the doctor, they make you better. And we don't consciously carry that, but we carry it unconsciously. And of course, NETs don't really conform to that model. And one of the things that I hear a lot from patients is patients saying, I genuinely don't know how to respond, and I feel a mixture of angry and upset when my doctor says to me, well, what do you think is best? And the burden of that, and how to acknowledge the burden of that in a consultation, because it's not that it's an inappropriate question, but it's about how it's framed and how patients are held in that dialogue. And this is the same for being rare. The anxieties that come up by being rare, that as someone put it to me, when I first heard that I was rare, I thought, rare? I have a rare cancer. That makes me special. That makes me precious. That means that not many people know what's going on with me, and there's not much research data out there, and when I go into a hospital for an ordinary procedure, people look at me as though I'm from another planet. Okay, so being rare complicates it. And as I've said before, the familial impact in the genetically inherited NETs is an additional psychological burden for many, many patients. The families, we have family members who say, let's talk about it all the time because it's good to talk about things. And then they have other family members who go, let's not talk about this at all because my preferred way of dealing with this is just to pretend it's over there. Please don't raise it. Okay? So living with NETs requires very high level, I would say, of psychological flexibility and resilience. And a image that we sometimes use with patients is this idea of a tightrope, or the idea of perspective. How you help your patients and how patients find a way of stepping into and their condition being here when they need to focus on it for scans or appointments or to understand symptoms, but also the capacity to put it down, because it's impossible to live with the condition always here and the emotional impact of it always here, because it would drive you crazy. So what we try and encourage our patients to do is to sort of do what we call a kind of fancy footwork, to be able to move from one foot to the other and to feel safe to put the condition down for a bit and get on with one's ordinary life so it doesn't take over. And that's different for different patients at different times. As one of our patients said, it's like walking a tightrope you can't step off. I can't relax too much into feeling okay, as then I've got sideswiped by feelings by something and I'm back to square one. But equally, you can't be preoccupied by it all the time because it drives you mad. And trying to find that balance is really exhausting. So it's about acknowledging that there's a background level of psychological work that is going on for NEN patients all the time, just managing the psychological and emotional impact of the condition. I'm guessing those of you who are in the room as patients will get some of this. Okay, so this is just a little bit of background to sort of that we're trying to really get out to healthcare professionals about what are the factors that affect the capacity to manage the psychological impact of NETs. And when we're talking about managing anxiety and uncertainty, there are external factors which again chime with some of the presentations earlier. We feel safe under certain conditions. And what I think we should be doing is helping our patients feel safe in their healthcare all the time. So it is very ordinary things, feeling safe, feeling listened to, feeling understood, feeling known, So much difficulty could be avoided for patients by having a reliable consultant that you see each time. That still doesn't happen in many clinics, and it's enormously distressing to many patients. Supportive and clear information, like Joe was saying, predictability and reliability, as Kathy was saying, say what you mean and mean what you say. Yeah? So I have had people contact the counselling helpline because it's the last straw that they've been waiting for, that appointment, that call from a consultant or a nurse with scan results, and it's got to 6 o'clock in the evening and it hasn't arrived. And the level of distress and tension that patients hold because of that can tip many patients who've been coping well over. So those are the external factors. The other things are what we call internal factors that are very unique to each individual patient based on your own individual histories. So your own particular personal capacity for seeking and building supportive relationships. If you've grown up in a home environment, in a situation where you have confidence and trust and expect people to be available to help you, that's a very different experience to, say, like a young man we worked with recently who'd grown up in care and was diagnosed with a NET. And he was someone who had no capacity really to believe that he would be taken up by the services that would be interested in him and learn how to navigate those hospital services. And we were able to put him in touch with a very good clinical nurse specialist, who I think probably saved his life actually, on the basis that she was able to reel him in to engagement with treatment and scans, because he was at the point of just complete disengagement. I can't do this, he said. So, you know, the capacity to build supportive relationships is very key. The capacity for trust, a willingness to accept change and find meaning, and the capacity to bear difficult feelings like anxiety, grief and loss. And some of those are, you know, patients have an innate capacity for, but certainly these are also things that can be built with good supportive care and counselling. So it's just important to know that it's not a fixed thing, it can also grow. So this is just a bid really to flag up with you particular patient groups that I think are particularly of need and just need mention when we're thinking about care needs. Adolescents. Now, adolescents with ongoing conditions are a bit of a handful, to put it bluntly. Why is that the case? Well, when you're adolescent, you tend to believe that you are somewhat immortal. Even if you are, in the case of, we see a lot of the sort of men adolescents, yeah, living with your condition, you've known you've had it since relatively young. Adolescence is the time where you might start going, along with many other things in your life, yeah, not really sure I want this anymore. I've been taking medication all this time. Do I really need it? I might just not take it for a bit. What, I have to go for another scan? I'm a bit busy. I'm going off to university. I might not bother for a bit. Yeah? So adolescents, because of their developmental stage, are much more at risk. I would also argue that they fall in between children and adult services in a way that means they disengage much more readily. If they are still engaged, there may also be all sorts of problems at home that you need to be aware of about how much mum or dad are shoehorning them into going. So just be aware that adolescents can drop off your radar, particularly if they don't have supportive family backgrounds. Menopausal women. Dear to my heart currently, but menopausal women are caught between a double whammy. Okay, so they have all the hormone surges of the menopause, and then they have all the hormone stuff going on from their condition. Trying to work out what is to do with what is very complicated. I constantly despair at the lack of joined up referral and thinking that still goes on in NET and NEN services. We worked with someone recently who was having a really terrible time and encouraged her to actually get a referral to a good gynecologist who would talk to her endocrinologist. Okay? It's not just getting the referrals, it's about getting people to move out of their discipline silos to talk to each other. And this endocrinologist and gynecologist were able to have a conversation, and she is much more stable. She's much more stable emotionally, she's much more stable physiologically. Isolated and unsupported individuals, obviously that's true. Those with comorbidities, again, let's encourage our consultants to talk to each other. Don't just as endocrinologists talk to other endocrinologists, talk to others. And of course those with psychiatric histories or a history of trauma. Okay, so, have I got, okay? So I just wanted to talk a little bit about the project that Kathy touched on earlier, which I think we're enormously excited about, really, which is attempting to bridge the gap that exists, that you discovered from your own survey in 2017 about unmet needs. And primarily this is about raising awareness of and literally filling that gap between what happens when patients are seen at hospitals and what they go home to live with on a day-to-day basis. So really about supporting NET patients through their particular cancer experience. And this is something I am very particular about. There is not a generic NET patient cancer experience. That's true at the physical level, but it's also true at the emotional and psychological level. So this all goes back to how is my particular patient at any one time dealing with their condition. We can't generalise in this sense. We want to publish data from this vulnerable patient population, and we want to make recommendations. We're very aware that we're a very small service, so we can't do anything in the sort of the wider sense without engaging other people to be aware of what is going on in the background for patients at the psychological level. So we want to talk to clinical nurse specialists, we want to talk to consultants, we want to talk to patient groups. And we also, one of the things we do want to do is set up a Living with Neuroendocrine Cancer training sessions that we can offer in blocks of 6. There are lots of these around for the existing cancer community, but as we've already looked at, neuroendocrine cancers don't fall into that particular way of thinking, and we would like to see these embedded into existing cancer services. I personally would like to see a neuroendocrine cancer psychological specialist attached to every NET specialist centre. I'd like it more widely, but let's start realistically. Who can be consulted, who can be referred to, who has a particular understanding that can then be advising consultants, but also be working with patients directly. We need to raise funds, obviously, so we put it under a project umbrella. I work 1 day a week with AMeND and 1 day a week with NET Patient Foundation. We barely advertise what we do. And the reason for that is because we can't advertise more widely, because we wouldn't be able to keep up with demand. So we're always trying to find this very delicate balance between making people aware that we're there, but not making people too aware so we don't set up expectations that can't be met. So any really great funding ideas, speak to Kathy, speak to me. Funding, of course. And we want to provide further online resources and leaflets and training for other counsellors and psychologists, healthcare professionals and patient groups. And I'm just going to finish very, very quickly because I didn't want this to be an add-on, but I'm afraid it is a bit of an add-on, which is all of you here work with neuroendocrine cancers day in, day out. Many of you are patients, and I just wanted to make a nod to the fact that you do a tremendous job absorbing a huge amount of distress that comes at you from your patients every day. And it's not talked about, in my opinion, enough, the impact of working with very complex, very difficult conditions. So I just wanted to say, you are doing something terribly important for yourselves in coming to this conference and this meeting, which is about your own care and your own support networks, because it's back to that little analogy, if you don't put your own oxygen masks on first, you can't support other people. So I'm just saying, I'm so pleased forums like this exist, and thank you very much for allowing me to be part of it. Okay.
That's great, thank you so so much. It would be really good if we could take some questions or really just talk about this, an area that's, I think, dear to a lot of our hearts, and really just try and think about ways that we can improve services that we're running ourselves to think about this. Simone, do you want that?
So I'm really interested in the GP education. Going back to your presentation, when we've tried to do that in Australia, it's been like we've tried to blanket, at GP conferences and talk about, oh, well, these are the symptoms you need to look out for, and the feedback was always, oh, we'll never see one of those. Oh, they're so rare, and it's like, well, you might have, and you've actually misdiagnosed them. So we went back to the drawing board and actually decided, okay, let's get patients to nominate their GPs or their primary healthcare, and let's survey them on what their needs are. So what are the GPs' education needs? And the results have been really interesting. So we've had about 60 GPs fill in a survey, which I actually think is, how difficult is it to get the GPs to actually really, come on board? But it was interesting. A lot of it was about this, living with NETs. They want to know about the psychological support. What was interesting was I found that there wasn't the gap between the specialist centres giving the information to the GPs, so that actually the communication was quite good between the MDT and the GPs. So that was something I was like, oh, good. But yeah, there was a lot around, symptom control and long-term relationships with these patients. So that will form our education modules and CPD points and that sort of thing. But it's interesting, to try and get to the GPs, because they are the social workers as well.
Yeah, for sure. And I think we tried to do this training when we asked GPs to take out, patients to take to their GPs like a training pack, which was really expensive and a bit of a disaster, really, in terms of we got it out to about 10,000 GPs in the UK, but they have so much reading material, they have so many emails, that they said, what do you want me to do with this? I was like, oh my God, we've spent a fortune on this and we shouldn't have done it, and we should have thought about it a bit first. So I think the idea of surveying is really important. And we did this on our first training, which is about just getting into the medical schools and trying to speak to the training coordinators, because they really like to have something a bit different, because I think they felt that, it's more interesting for the trainees to have something a bit weird than it is just to the normal program that they go through. So they were really very open to having, they only offer you an hour, but they were very open to offering that to come in. But yeah, understanding the treatments was a big thing, not really understanding or using those sort of treatments in patients, PRRT and bloods that required afterwards that often had to be done at a GP surgery. They weren't quite sure why they had to do that and what would happen if they didn't, and should they chase the patient if they didn't come in for their bloods. So there was all that kind of thing. Again, it's like post-op care, which I think was important.
And what's interesting is that a lot of the treatments in Australia now, or the SSA and the injections, are now being given in the communities at their GPs. So they need to know not just how to deliver it, but what are all the things that go with that too.
Yeah, and I think every time a patient goes in, often to the practice nurse for their injection, they want to talk about other stuff too. So you have to have a bit more of a knowledge base about NETs rather than just giving the injection. But yeah, it's a long journey yet, I think.
I have a couple of questions, partly to you, Kym, but also, well, you don't. Whatever. Yeah. So one that comes up as a question to me, coming from Central Europe, which is now a resource poor setting and is becoming resource poorer as we speak. So because Hungary and I think Bulgaria, it's a very similar situation. So how can you adapt these models that currently seem to be so focused on the UK experience? How can you apply these models to different settings? That will be one, but maybe that's an overarching topic, and not just for, yes. Yeah, yeah, yes, yes. And so that leads to my next question, which is that there are networks of oncopsychology across Europe. To what extent do you work with these people? Because also there are different approaches. For example, we in Germany use a lot more psychodynamic and psychoanalytic approaches rather than CBT, which is time consuming but also has good results. And then my other question is to what extent you speak about sexual health, which is now a huge topic in oncocytology. There's a lot of talk going around about that, and not just in obvious targets like breast cancer or ovarian or various men's cancers, but in other areas as well. So do you touch upon that? Because when we try that in other patient communities, I mean, even when I published about that in the BMJ, people shouted my hair off. Not that I have so much, because they were saying like, why do I want to force GPs to talk about sex on top of everything else, right? So this really is a very sensitive topic. However, it is part of your health. I mean, it's so yeah.
Okay, I'll try and answer each of those separately. But what we're doing at the moment is trying to build more connections with. Can you hear? Am I on? Is that better? Can you hear me? Okay, I'll shout. Okay. So one of the things we're trying to do at the moment is have more crossover with the psycho-oncology community. We have some, but it's very interesting how they work within a very particular sort of frame. And what we're trying to do is, so there is a British Psycho-Oncology conference, which we're hoping to present at next year, to say these are the particular needs of patients with rare and ongoing cancers. So the idea of cancers that are sort of more like a chronic condition. So trying to get much more out there about this. Certainly, the approach that, I mean, there's so many different treatment approaches, and in a sense, it is all, what I believe it all comes back down to is about relationship building, and that's absolutely key. What you were saying in terms of sexual health is something, again, that comes to us fairly regularly, because inevitably when you are living with an ongoing condition, it affects your sexual desire, it affects your relationships in all sorts of different ways. And patients aren't being asked that information in a sort of gentle or appropriate way in clinics. And I don't think that's just a British thing. It's a general experience, my guess. So again, how this is just made an ordinary part of the conversation of, how are you getting on with your condition? How's it affecting your relationships? How's it affecting how you... Certainly one of the things we deal a lot with is body image issues. So sort of scarring, visible scarring, big scarring that can happen is a real issue for some people. Not for all, but it is, it can be a big thing. Particularly, for women, I would say the men can sometimes, again, not always, and I don't want to generalize, can sort of see it as a bit more... It's a little bit more macho, but for the women, we've worked with a number of women who've had neck surgeries and became a little bit agoraphobic for a bit, didn't want to go out, didn't want to be seen. So there's a lot. I mean, there's just so much to pick up, but yeah. Thank you.
Yeah. I just wanted to make sure that it's on the agenda, that it's something that we don't forget about.
So, if they answer something and I don't know what to do about that, so it's easy just not to ask because you're not quite sure what the response
Can I
will
just
be.
say something? This is something that I think has to be key to when we're talking with healthcare professionals. Healthcare professionals are all about doing. You feel that you have to do something if you've asked a question or a problem comes up. And what I think we need to get across is sometimes the doing is the asking the question, and the doing is the listening. It's the care. You may have suggestions that can be made in that regard, but just acknowledging the difficulty and spending time to say, yes, that I can see that's really difficult. That is enormous for some patients. It should not be underestimated.
Yeah, in Ireland, mainstream cancers, every patient gets access to a counsellor or a psychologist, and they can just speak to somebody and talk to, what they're going through. But for NETs, we don't have anything like that. It's just not in the system. And I'm just wondering, in terms of how to get it out there, with ENETs and the Centre of Excellence accreditation process, is it part of it, or can we pursue to try and get it part of it, that there is some sort of access to service for NET patients through that, because that's a method or a pathway to getting it out there.
Yeah, I mean, presently, just a specialist nurse is what's required in terms of the multidisciplinary team extension, I guess. But yeah, I mean, I think it'd be a really good idea, and maybe now with the new ENET satisfaction survey that will hopefully be launched, maybe there will be, I mean, I can't quite remember what's on the survey now, but maybe, there will be responses that say, I don't have any psychological support, and that might be something that can be added onto. But I mean, I agree. I mean, I think the wider multidisciplinary team is what's really important here. When I mentioned earlier, that's the reality for the patients.
But maybe this is something that INCA can
Yeah.
promote and push with ENETs.
Yeah, for sure. Well,
and they've asked to be referred to cancer counselling services in their. They've been told that they can't because of where the stage of their cancer is. They're not allowed to access. But it's completely ridiculous because the level of distress that they may be experiencing may be massive, and they then end up sort of being channeled down to sort of using antidepressants or anti-anxiety medication, and it's actually, in my opinion, not appropriate. So, there's a lot to think about there. We do have some great hospitals in the UK who have psychologists who slip their NET patients into their services, technically shouldn't. So they do it under the radar. But, that's not good enough, really. That's based on goodwill.
I wonder if it'd be worth asking some of our medical colleagues what their experience has been.
I can speak from the German point of view. Actually, we have a program known as the Comprehensive Cancer Center in our universities, and when we speak in the MDT, we take care that we do have, when a patient wants, the psycho. And many a times I also see such issues like suicidal tendencies. Patients actually speak about that. They don't want to live. They don't want to take any further treatment because they say, I'm going to live only for 1 year. Why do you want to do anything with my body? In such cases, we do offer those patients the psycho-oncological consultations. And in CC, Comprehensive Cancer Center in Germany, it's a must. You must offer your patient these options.
So maybe I can speak in Canada. I mean, each province is slightly different. We do have a similar system of cancer centers where there's supposed to be psycho-oncology, but it certainly isn't enough to provide it to everybody. And I think what's fascinating about your presentation is you articulated very nicely about the differences between, the cancer services that are provided are meant for, for lack of a better term, sort of the bread and butter of what the cancer system is seeing, right? Genetics, but also things like patients with stage 4 pancreatic cancer whose survival time is measured in weeks to months. How is that? Those are very important needs, but they're very different than what we described just here. So a couple thoughts that were coming to my mind was, one, I think it's really important for you to share this information. The stats that you showed, which was like 150 patients, was alarming, right? Those are alarming stats. Even for me, I was quite surprised to see how high they were. So I think the medical community needs to it would be a great opportunity to take a role to share that with those kind of numbers with the medical community, because part of it is avoiding those stressors, like you said, that would start making the situation worse. Part of it's the disease, but part of it's the experience, right? And it's separating, try to make the experience better so you're not adding to the stressors of the disease. And then the other area that we're starting to look at through social work, which we're sort of filling some gaps is financial toxicity. Because a lot of the finances, like a lot of those things like relationships with families, et cetera, can be also triggered when there's financial pressures, when people are taking multiple days off of work to come see people. They have an appointment with 4 different physicians and have to take 4 different days off work. So I think those are all sort of areas that might also be able to be acted upon.